Well, good evening, everyone. Can I just get a quick sound check? Sounds good. That was very quick, John. Just get a yes, make sure everyone can hear me, and then we'll get going. Great, thank you very much. Welcome along. It's 7 o'clock, so we'll get introducing. Welcome back. A lot of familiar faces from last week and from our previous series. So welcome back to our online weekly webinar. So tonight we're doing the first two parts, which is on anatomy and physiology. As in the marketing, obviously we've been aiming this series at those of you progressing through the FREC pathway, but of course this is also useful to those of you that are studying at any level, or of course just want to come back and do a little bit of CPD over the basics. So anatomy and physiology for the next couple of sessions. Obviously a few of you from last week where we talked about continuing professional development and the requirements of that, again particularly aimed at the FREC pathway, but of course I've used paramedics as an example of how we put that together. So moving on with the series, so a little bit about us. SDC Training Solutions is a company that's been around for a couple of years now. We are a first aid and pre-hospital care training provider. We started delivering first aid, obviously quickly branched into doing the FREC range of courses under Qualsafe, which is where we kind of really focus our attention still. We are looking at developing a little bit more in the realms of continuing professional development, CPD opportunities for other healthcare professionals, and of course these webinars form part of that. So we do hope they're useful. Obviously we want them to be free and readily available to everyone that needs them. So that's the whole purpose of these. So for those of you that haven't been along before, so I'm Innes, I'm a paramedic. I've worked predominantly in a couple of the ambulance services, London and South Central, and now work in a GP surgery in South East England, but still have bank contracts with the ambulance, just to keep up to date with everything that changes there. So been a paramedic for a few years now and have a special interest in cardiology actually, which is part of what we're going to talk about this evening. So if you have any questions about that, then please do let me know. It's just gone 7 o'clock, so I think good time to get going. Good to see a fair few of you out tonight, so thanks for coming along. If I can get the slides to go on. Okay, so obviously first and foremost we are a FREC provider, so you'll forgive the plug of our upcoming courses. Those of you that are working through the pathway at the moment, if you're yet to do your FREC 4, we do have a couple coming up in May, one starting on the 15th of May in Aylesbury, one starting on the 22nd of May in Rotherham. We deliver our FREC 4s over 3 blocks, which is how they were kind of designed to run. And you complete your workbooks in between those. So if anyone's interested in completing their FREC 4 with us, please do get in touch. There is a discount code you can use, webinar 10. If you pop that in the checkout on our website, you'll get 10% off the course, all of our courses. So we do have FREC 3s running in June, our next ones with space weekend courses. And for those of you that haven't done any of the courses yet, we do have a weekday one starting in, can't see because of the chat box, 17th of May, that one starts. So ILS, we've got an ILS coming up soon. Those of you that have your FREC 4 already and need to do the annual refresher course, the ILS course, we are running that on the 2nd of May. There's a couple of spaces left on that if anyone's interested. Obviously with the discount, £112.50, including the Resource Council textbook and a little goodie pack that you get. Plus we cover a lot of subjects that aren't always covered as standard on the Coursafe ILS course. Safe administration of life-saving meds, we have one of those, or 2 of those in July, Aylesbury and Rotherham, for those of you, again, that have FREC 4, work for a CQC registered organisation and want to add that bolt on. As I say, if any of those courses interest you, or even later on in the year, do take a look at our websites, use the discount code, or get in touch if you want to know more. So that's all the sales over and done with, so we'll get on with tonight. Welcome along. So what's the series all about? This is what we've kind of come up with so far. We did CPD requirements last week, sorry. It's been a busy week. Anatomy and physiology for the next 2 sessions. We're going to cover 6 areas that are quite useful to well, anyone should have a basic understanding of these 6 areas. that we'll talk about later. We're going to talk about some common pathophysiology, that is the study of disease. That will be in a couple of weeks' time. We're going to start going through those. That will probably be a two-part session. We're going to do some maternity care. Those of you that joined us last year for our first run of these webinars, we didn't include maternity care. We're going to do that this year. Patient assessment and specifically paediatric assessment will form a couple of sessions. We're going to talk about sepsis, oxygen and Entonox guidelines. There will be a session on ECG Basics. Of course, we do have our 8-part series that aired actually around this time last year. So that's still on YouTube. We will be refreshing that at some point this year as well. And of course, we'll do a session on the intermediate life support or immediate life support. That won't obviously count as your annual refresher, but it's something just to keep your head in the game with regards to that. So hopefully you'll find these subjects useful. Tonight we're going to talk about the big three, so respiratory, cardiovascular, and central nervous system. So there is a lot to cover tonight. This is quite a heavy subject evening. There will be a Q&A session at the end, but of course we want this to be as interactive as possible. So if you have any questions as we go along, please do throw them in the chat. I'll keep an eye on that. And if we get an opportunity to answer them, we will certainly do that. The next half of the A&P session will be next week. It's looking like it's going to be, it's actually going to be next Wednesday again. So we're sticking with Wednesday for one more week. And then our plan is to go back to Monday evenings, which is our original slot. I've had to do Wednesdays just because of my work schedule at the moment. So we'll be going back to Monday after next week. So next Wednesday and then the following Monday. So next Wednesday, we'll be talking about musculoskeletal system, gastrointestinal, and the genitourinary, which are technically 2 or 3 systems, but all kind of clumped together. So as I say, these 6 subjects, if you like, not just for FREC, they are very useful in general for people to have a good understanding of. So we'd like tonight to be interactive. We've got Mentimeter on tonight, so grab your smartphones, have those handy, and just go to menti.com. It'll ask you for a code, and just wait there. When we get to the interactive slides, I'll give you the code to put in, and you can answer the questions. Makes it a bit more fun and engaging. Of course, throw anything in the chats, as I've said. Charlotte's in there as SDC admin, so if you need anything, any technical help or anything, she can help you out. And as I say, I'll keep an eye out for any questions that are coming in. You can tweet us, text us, or email us, and that's, of course, after the webinar ends as well. If you've got any burning questions that you didn't get a chance to ask, then please do get in touch. I'm more than happy to help. So as before, we've put the page reference numbers at the top left. These slides will be available on our website, hopefully from tomorrow. The books we're referencing are Ambulance Care Essentials and Ambulance Care Practice. Those of you that are doing FREC, your FREC providers should be providing you with these. You should be provided with Ambulance Care Essentials as part of your FREC 3 package, and Ambulance Care Practice as part of your FREC 4 package. So if you do need to buy those, if you haven't been provided them, or if you haven't done the FREC courses yet, they are available to purchase through our website with free delivery. Although I would say don't bother buying them if you plan to do a course, certainly with us, because we include these anyway. So Ambulance Care Essentials and Ambulance Care Practice, you'll see at the top left, the page numbers will appear as we go through, so you can reference back later. So let's give Mentimeter a go, shall we? So grab your smartphones, go over to menti.com and just stick in the code that you can see at the top. Unfortunately, I can't see the code because I've got a very unhelpful toolbar sitting there. There we go. Right, so we go to menti.com, put in the code 35194182. So menti.com, use the code 35194182 that's shown at the top of your screen now. And we're asking the question, what are the functions of the respiratory system? So pop some text in there, throw them up on the board. Thanks, Charlotte. She's just put it in the chat as well if you're struggling to find it. 35194182 is the code to put in. I think you get 3 answers each. So it does have some kind of profanity filter, so I'm led to believe you can't swear, but I'm sure someone will test that. Good. We're starting to see some answers come up. Lovely. I like it. Great. Well done, guys. Keep throwing those answers in there. So if you're just joining us, I'll see the numbers just jumped up a bit. Menti.com 35194182. You can take part in this interactive session. What are the functions of the respiratory system, we're asking at the moment? So some great answers coming in. Gas exchange being the most popular. Breathing. I like that. Absolutely. What's the purpose of breathing? It's to exchange gas. Gas exchange, get air into the body, supply oxygen, remove waste, remove CO2, provide oxygen, Expel CO2, keep you alive. I like it. Staying alive, bit of Bee Gees. Good. Remove CO2, spark oxygen, lovely. Well, nobody's put anything wildly wrong up there, which is great. So there's still time. Excellent. Great. I like it. Yeah, gas exchange, absolutely. Fantastic. Good. I like it. We're on the right lines. So let's flick back. Sorry, this isn't quite as slick as it normally is. The computer's been a bit slow tonight. So what are the functions of the respiratory system? First and foremost, gas exchange, which you all said, regulation of pH. I'll come back to that. Filtration of inhaled air. What we breathe in ultimately needs to be filtered to reduce the likelihood of us getting chest infections and things like that. Speech, passing air in a controlled fashion over our vocal cords allows me to talk and sing sometimes, if you can call it that. And of course, taste and smell is actually part of the respiratory system as well, isn't it? As our special senses. That's all kind of built into what our system can do. So, no problem, Rob. Welcome along. You haven't missed too much. We've just started with the respiratory system, so get settled in. And do feel free to take part in the next interactive bits that will be coming up. So regulation of pH, what do we mean by that? So that's the kind of acid-base balance of the blood. Those of you that have done chemistry, you know that carbon dioxide, when it's dissolved in the blood, it forms carbonic acid, you know, and our blood has to be within a certain range of pH for our body to survive. It's just quite a tight margin. They say 7.35 to 7.45. So just slightly alkali of neutral being 7. So, of course, if we allow our blood to become too acidotic, it can cause lots of problems around the body. And actually, the respiratory system is one of the first line mechanisms for getting rid of excess carbon dioxide and thus allowing the blood to become more alkali. So if we're going into a bit of acidosis, and we can get rid of excess carbon dioxide and increase that pH, so reduce the acidity of the blood and allow that to return to normal. So the respiratory system has a big part to play in that. It's certainly a lot quicker than the metabolism, which is obviously in a little bit more detail, which is part of the gastrointestinal system's function to maintain pH that way, but it's obviously a slower way of doing things. So gas exchange, we'll talk about that in a little bit more detail. Obviously, the functional part of the lung being the alveoli, which is where that gas exchange happens. And when you'll hear this term gas exchange all the time, what does it mean? It's bringing oxygen into the body and it's getting rid of excess carbon dioxide. At a very basic level, each cell in the body uses oxygen, and in return, it gives the blood back some carbon dioxide. So then obviously the blood coming back to the heart and then for going into pulmonary circulation is high in carbon dioxide. The air we breathe in is relatively low in carbon dioxide and obviously high in oxygen, and the two switch over nicely in the lungs. So we'll have a look at that in a little bit more detail. As I said, filtration of air is to prevent, it's a defense mechanism effectively to stop anything getting into the lungs that we don't want to be there. Speech, obviously useful for communication, and taste and smell obviously just makes everything more enjoyable with food and sometimes less enjoyable with the work in terms of smell, but there we go. That's part of it. So let's have a look at some of the anatomy before we crack on to the bulk of the physiology of the respiratory system. So the anatomy is fairly simple, actually. The whole function of the respiratory system is to get air in and out of the lungs. I remember on the first day of ambulance school being told that air goes in and out and blood goes around and any variation of that is a problem. And actually, it's still very true to this day. Certainly, when you talk about advanced life support, nothing really has gone into, nothing's changed that. So getting the air in and out of the alveoli, which we'll come to in a minute, which are the functional parts of the respiratory system, is the whole purpose. And this is just a rather complex network of getting that air in and out and protecting it to some extent. The body is pretty good at protecting itself for the most part. So you can look at the diagram on the left there, which is a cross-sectional diagram of a patient's face, and you can see that the nose is relatively hollow behind the nose. Obviously, there are some bones and structures within that just to help filter air and kind of warm and moisten it as well. But for the most part, it's fairly hollow, and that's called the nasal cavity. The back wall of it is known as the nasopharynx. There's three parts of the pharynx: the nasopharynx, the oropharynx, which is at the back of the oral cavity. The oral cavity, you can see there, is obviously occupied predominantly by the tongue. The tongue is a muscle. The tongue can relax, obviously, and when we talk about an unconscious patient that's supine on their back, when the tongue is relaxed and flaccid, it can fall to the back wall of the oropharynx And it's that actually causes snoring and to some extent some airway occlusion. And when you have an unconscious patient lying on their back snoring, it's because their tongue's on the back of the oropharynx. And of course, in the immediate life support session, we'll talk about some airway management at the different levels. But the aim there is to get that tongue forward either through manual manoeuvres or through airway adjuncts. The next bit really to talk about is the epiglottis. It's not labelled on the left diagram, but it's this flap of skin here. It is labelled on the diagram on the right up here. The epiglottis is a flap of skin that snaps shut when we swallow, actually, and the idea is obviously food comes down through the oropharynx in the same way that air does, but we want food to go down the esophagus. Just to excuse the American spelling. The esophagus at the back of the trachea is where our food goes down to the stomach. We don't want our food to go into our lungs. Our lungs can't do much with the roast beef. The stomach is much better at dealing with that. So similarly, the stomach isn't so great at dealing with air, as we know when we deal with cardiac arrests and things like that. So the epiglottis snaps shut. It stops food going down into the trachea, but we're here to talk about the airway. The epiglottis, generally when we're breathing, is nice and open. Air passes in and out through the larynx. The larynx is also known as the voice box. The larynx is this whole area where the two tubes join, effectively, the esophagus and the trachea. And then you can see that the trachea carries on down. It splits into two, and it feeds each of the lungs with air. So let's look at that in a little bit more detail in just a second. There's some useful anatomy, hopefully, here of the mouth. I find this diagram quite useful for some of the posh words that we're describing when we're looking in someone's mouth. The uvula being the dangly bit, the palatine tonsils being the ones that often get swollen in tonsillitis and quinces or peritonsillar abscesses. It's nice sometimes to know the technical names for the arches. If you're looking in someone's mouth and trying to describe what you can see, this can sometimes be useful. So, and the gingivae being the gums, obviously gingivitis being gum disease for the posh words. And there we go. So that's going to be available. So yeah, I was going to say, yeah, it's a good one, Casey. Actually, yeah, we see a lot of people's mouths that perhaps we didn't want to. So I think most of ours are nasal still. So filling things up people's noses is always joyous. So, and of course, our courses at the moment, we're doing lateral flow testing every morning. So it's the morning ritual, isn't it? The thermometer in the ear and the nasal swab. So I keep telling all our students they should be thankful we haven't gone for the rectal temperature probes because they're far more accurate. But there we go. This is the view you get under laryngoscopy. Laryngoscopy being the laryngoscope blade that paramedics use to intubate with, and as you know, has been discussed at great length recently. It is now kind of best practice when placing supraglottic airways, but it's obviously just follow what training you've had up to date. I believe that things may be about to change with regards to the FREC 4 training, but that will be announced soon. So we have the vocal cords there, you can see, and that is the entrance to the trachea. It's the vocal cords, obviously, that vibrate and allow us to talk and sing so beautifully, and it's air passing over those in a controlled fashion that does that. You can just see the blurred kind of bit of tissue at the top there is the epiglottis, and ordinarily that would, as I say, snap shut and stop food going down that hole when we swallow. A little bit more kind of anatomical view there. So there are some bones. This is the larynx, effectively the voice box. You can see that we focus just around the trachea there, but the voice box is protected by some bony structures. Fun fact is that the hyoid bone there you see at top left is the only bone in the body that's not connected to another bone, which I always thought was quite fascinating. You can see the epiglottis depicted again there, some of the vocal cords, and then the trachea. The trachea has cartilaginous rings around it so that it retains its structure. Unlike the esophagus, which is kind of compressible and stretchable, the trachea is relatively rigid, certainly at its front anyway. The back does allow some movement for larger food boluses to be swallowed. And here we come down into the lungs. We said that the trachea breaks into two. So you have the main bronchi, main bronchus, left main bronchus, right main bronchus. They split and obviously feed their respective lungs. Within the lungs, they branch out. So you have primary, secondary, and tertiary bronchioles. So primary bronchus and then it kind of separates into smaller bronchioles. Bronchioles just basically means smaller bronchi. In the same way you'll hear in the cardiovascular session in a sec, that arteries that become smaller become arterioles, veins that are smaller are venules. So bronchioles just means a small version of a bronchus. So as they separate, they become called bronchioles, and then eventually they terminate at these things called alveoli. A couple of things to note with the lung: obviously, your heart sits in this space; it sits just behind these lungs, and off to the patient's left-hand side, which is obviously right-hand side as you're looking at the screen. You can see that the left lung is slightly smaller. It only has 2 lobes if you look closely. So it's got an upper and lower lobe. It doesn't have a middle lobe like the right does, and that's because the heart occupies some of the space that the right lung would have occupied if the heart was on that side, if that makes sense. So left lung is slightly bigger. Also, it's not shown particularly well on this picture, but another fun fact is if you inhale something and it does go into the lung, it's more likely to go into the right, because the right main bronchus is slightly straighter, certainly in line with the rest of the trachea, and that's just because the left main bronchus, left primary bronchus, tends to curve up a little bit just to make space for the heart. So another fun fact: if you inhale something, it will go into the right lung more than likely. It's a useful diagram. I had this on my cheat sheet at work for a little while, just to still have for listening into lung sounds and actually deciding which lobe you're hearing things in. You're taught the very basics of listening into breath sounds on your FREC 4 course, and this is just to kind of help you take that next step with your training. Certainly on FREC 5, you're expected to know your breath sounds a little bit better, and those of you that are going on to paramedic training will definitely need to get good at this. So trying to decide which lobe we are listening to, depending on which rib space we're in, takes a bit of practice, takes a bit of doing, and of course learning the different sounds and things like that, which we won't have a chance to cover tonight, but we could certainly do a CPD webinar on breath sounds if people would find that useful. So hopefully this makes sense. We're looking at the lungs, well, we're looking at the patient, as those are standing in front of them here in the center picture, left and right lung. And you can see these are the ribs numbered, the spaces in between the ribs. If you listen in between sort of the second, third, you're listening to the left upper lobe. If you listen at the front between the 6th and the 7th, you're actually, sorry, the 7th, yeah, 6th and 7th, you're listening to the left lower lobe. You can see there that the middle lobe tracks along the 4th rib in this case. So in the right lung, so you can listen between 4th and 5th or 5th and 6th to hear the middle lobe, and again below the 6th to hear the lower lobe. You can see here that on the this is side view, so this is the right side of the patient looking at them. So imagine they're lifting up their right arm, and again imagine they're lifting up their left arm. So question from Rui: you are taught the very basics in your FREC 4 course, so you don't need to know them in any detail by any means, but obviously the better you are at these things, the better you're going to be able to figure out what's wrong with patients. So, for instance, being able to tell the difference between an infection, between coarse crackles, as we call them in infection, versus fine crackles in pulmonary edema, which is fluid on the lungs. Things like that. It takes a bit of practice, and generally speaking, you have to be out there kind of listening to lungs quite a bit to pick up on those. It certainly took me a while to feel comfortable with that. So, but yes, you are taught the basics, but you know, don't it's not in any real detail. So at this stage anyway. FREC 5, if you do that, definitely much more. Good. So we have the alveoli. These are the functional part of the lungs. Okay, so air goes in and out as depicted by the little tube here. This is a terminal bronchiole. It's a small bronchus. And we have a blood supply. So this blood supply, these are the little venules that have come from the these are little arterioles that have come from the heart. They're arterioles because ultimately so they're high in CO2. They've come from the right side of the heart, which deals with the deoxygenated blood, the blood that's relatively high in carbon dioxide. They're going to supply these capillary beds, and within these capillary beds, as you'll see on the next slide, this is where this gas exchange takes place. So, and of course on the other side, these are little venules which are going back to the left side of the heart in order to be circulated back nice and rich in oxygen. So you have the conducting portion, which is the little terminal bronchiole, and then you have the respiratory portion. this is the lungs in general. So the last little parts of the respiratory system, these little terminal bronchioles, are capable of conducting. Excuse me, put my teeth back in. These are capable of gas exchange as well, but predominantly we think about gas exchange taking place in the alveoli themselves. The conducting portion of the respiratory system refers to all those pipes we've just talked about. So from the mouth and nose down to the trachea, the left and right main bronchi, and into the bronchioles as they split up and decipher all over the lungs. So of course, these little alveoli appear all over the lungs. They are completely full of these as much as possible, because obviously we want the lungs' main function is to allow this gas exchange to take place. So what does that look like? Oxygen and carbon dioxide will diffuse along their concentration gradients. So what does that actually mean? So we hinted at it just a minute ago. This blood coming from the right side of the heart, this is coming through the pulmonary arteries, and obviously they're splitting down into arterioles and down here into these little capillary beds. So these pulmonary arterioles bringing deoxygenated blood, because don't forget the body has used the blood, it's sent it back to the heart to pump back to the lungs to be oxygenated. It's coming in and it's full of carbon dioxide and it's low in oxygen. When you breathe air in, the air comes into these little alveolus, the little air sacs at the end of the terminal bronchioles. The air that you've just breathed in, provided the environment is good, is rich in oxygen and low in carbon dioxide. What we mean by a concentration gradient is that actually if the blood coming up here is high in carbon dioxide, low in oxygen, in here we're high in oxygen, low in carbon dioxide, we've got two concentration gradients. So carbon dioxide will naturally want to seep that way because it goes from areas of high concentration to areas of low concentration, and oxygen will naturally want to seep that way because it will go from areas of high concentration to areas of low concentration. And then, of course, this little capillary turns back into a venule, and that venule goes back to the left side of the heart, now rich in oxygen, low in carbon dioxide. I hope that's made sense. That's what we mean by gas exchange. This is the diffusion process that's going on at the alveolar level. And this is the absolute kind of nuts of what the respiratory system does. The whole point is to get air in and out of these sacs so that this can take place. When we look at the pathophysiology session in a couple of weeks, we'll talk about some respiratory illnesses and how this gas exchange can be impaired in certain ways. But that's kind of the basics. If you can understand this, then you'll understand why lots of things go wrong in the respiratory system. I'm going to talk about the muscles, some of the muscles that are used. So predominantly when we're here sitting at rest, we're using our diaphragm. The diaphragm is this kind of curvy muscle at the bottom here. When it contracts, it actually flattens. When it flattens, it brings the lungs down with it. So increasing their area. If you increase their area, you decrease the pressure. And of course, air comes in through the path of least resistance. That's through the mouth and nose, through the trachea, main bronchi, and into each lung, and starts filling up those little alveoli that we just saw. So the main mechanism of breathing when you're at rest is by your diaphragm flattening, okay? And that's an active motion, and then the passive motion of exhalation is just allowing that diaphragm to relax again. As it does so, it curves back up, it squeezes the lungs. As you reduce their area, you increase the pressure. The air leaves the lungs through the path of least resistance, in this case, back out through the mouth and nose. Hopefully that makes sense. If we need a little bit more than that, though, we use our intercostal muscles. Getting the words out tonight. Been one of those weeks. So the external intercostal muscles shown in red there on in between the ribs. In between each rib, you have groups of muscles. Those external intercostal muscles can allow the chest to rise up, so they actually lift the whole rib cage up. And again, they increase the area of the lung. If you increase the area even greater, you decrease the pressure even more, and you allow more air to be kind of sucked in through a vacuum. And in the same respect, they are a passive motion to allow the rib cage to retract back to its normal size. You have the internal intercostal muscles shown there in blue, which can do force exhalation as well. It's less usual to force exhale than it is to force inhale, if that makes sense. But we are capable of doing it when we're doing heavy exercise. Of course, you do kind of pant and you do kind of force exhale, and certain lung conditions that we'll talk about cause you to use more effort in exhalation as well. And then, of course, you have the third little group here, which is the sternocleidomastoids and the scalene muscles, which are your true accessory muscles up in the neck. When you see people that are really struggling with their breathing, we'll talk about this more in pathophysiology, you can often see these muscles or the tendons of these muscles becoming quite prominent in the neck. And in the old and young, you can sometimes get what's called head bobbing when they're really going for it. So that's the kind of muscular control. So the diaphragm, first and foremost. If we need a little bit extra, we use the external intercostals. If we need further still, we can use the accessory muscles in the neck. If we need to force exhale for any reason, we use the internal intercostals. But of course, we have much greater control over our forced inhalation than we do over forced exhalation. Hopefully that's making sense to anyone. If there's any questions, please do pop them in the chat, and I can go through anything that's not making sense there. And how do we control respiration? Lastly, so we have to bear in mind that ultimately we have both voluntary and involuntary control. It's one of only a few systems or control circuits in the body where you have both functions. But we have the ability to control our breath to a certain extent. The body isn't going to let ourselves kill ourselves by doing it. So we can't hold our breath to the point of death. We can hold our breath. Some people can train themselves to do it to the point of losing consciousness, but as soon as you do, your autonomic nervous system takes over and you breathe again. But you are able to breath hold. You're able to control your breathing rate. If someone told you to breathe 10 times a minute, you could probably do that. Or certainly if I said breathe every 5 seconds, you could probably do that fairly well. Likewise, if I said hold your breath for 20 seconds, most people would comfortably be able to do that. We can talk, we can sing, we can play musical instruments. We have a huge amount of voluntary control, but we also have a lot of involuntary control going on. Because actually we very rarely think about our breathing, do we? Certainly when we're asleep, we're not thinking about breathing. And for the most part of the day, unless we're doing some kind of hypnosis or otherwise, we're not really thinking about our breathing too much. So breathing, when it's involuntary control, is chemically controlled. So it actually responds to rising carbon dioxide levels in the blood. Remember I said that makes the blood more acidic. You have chemoreceptors in the blood that respond to that rising acid, and they tell the lungs to breathe faster. So then we have, so just a little bit of detail there. So the chemoreceptors are in the aortic arch, the carotid arteries, and within the brainstem itself. The signals go up to the respiratory centers. The respiratory centers in the human brain are kept within the pons viruli and the medulla oblongata, which are the two areas of the brain stem, which we'll have a look at briefly in the central nervous system anatomy that's coming up towards the end. So that's the theory bit over. Let's just have a little check to see how much of that's sunk in. We've got a couple of quiz questions coming up when I can get my screen to share it with you. So let's go to the next one. Oh goodness me, we're having some computer issues here. Let's go. Doesn't want to advance. There we go. Here's the next question. Right. Let's have a little think then. So a bit of physiology for you. Which of these would be true in the case of an airway obstruction? So pick up your phones again, go to menti.com and use the code 35194182. Thank you, Charlotte. It's just gone in the chat as well, 35194182. So which of these would be true in the case of an airway obstruction? Would oxygen levels in the blood be high? Would carbon dioxide in the blood be low? Would carbon dioxide levels in the blood be high, or oxygen levels in the blood not be affected? So oxygen high, carbon dioxide low, carbon dioxide high, or oxygen unaffected. Normally it doesn't show the answers until it hides them. Oh, there we go. Perfect. So you have a little, so 35194182. A, B, C, or D, which one do you think is true? Give everyone a minute just to. I think there's a bit of group mentality going on there, but yes, you're absolutely right. But I think everyone's just gone, well, when everyone else is voting for C, it must be C. It is C. But that's All good. Well done, people. So that's obviously made sense. Let me go on to the next one. So we're now going to start talking about the cardiovascular system. Cardiovascular system, obviously being the heart, blood vessels. So same question as you had at the beginning. What are the functions of the cardiovascular system? What do you think it's there for? Pump blood? You're on a minute there. You get up to three. It's the same number, 35194182. We'll go. There we go. Very good. It's all starting to wake up now. Perfect. I like it. So pump, internal respiration, good. Absolutely. Transportation. I like it. Some nutrient transport, hormone transport, brilliant. Transport chemicals, I like it because it's not just oxygen and carbon dioxide. Transport blood to the tissues, blood delivery, perfuse organs, yeah. Very good. A, excellent. A for effort. Push oxygenated blood, transportation device, pump, very good, perfect. So yeah, there's some good stuff coming up there. Most people are going for pumping blood and perfusing organs. Great. Removing waste, yeah, very good, perfect. Let's go back to here then. So cardiovascular functions, indeed, transport of nutrients, removal of waste, hormone transport, regulation of temperature, reproduction, and the immune response. Okay, what does all that mean? So other than just oxygen and carbon dioxide, which we know the blood transports, oxygen to the cells, carbon dioxide back again, and then of course in the lungs in reverse. It also carries things like glucose. It also carries other kind of hormones. It covers other endocrine kind of signals, anything that's any hormone, any kind of chemical messengers that are released into the blood, it's going to carry to the target organs or just generally spread them around, depending on what actually it is that's being carried. But nutrients, we think about glucose predominantly. Removal of waste, we're thinking things like lactate, we're thinking things like urea. Urea makes our urine. We're thinking about carbon dioxide, of course, first and foremost. Hormone transport, so slower kind of, we'll talk about the central nervous system a little bit later, which is one method the body communicates with organs. Hormones is another way. Hormones is when we want to talk to large areas or when we want a very big kind of systemic response to something. We use hormones instead of the electrical signals. Regulation of temperature is also controlled to some extent by the blood and again through chemical messengers that are released and hormones that are released. Reproduction is a function of the cardiovascular system and the immune response. So we are probably going to do a section on the immune response, and actually it might naturally fit in with the sepsis talk that we're going to talk about. So we will talk about how the immune system works in a little bit more detail later, but of course white blood cells are the general mediators of the immune system, and of course they are part of the cardiovascular system, they're part of blood. So we will talk about the immune system in a bit more detail with sepsis. So cardiovascular system is a general overhaul. We'll think of it as your central heating system. You have a pump. The pump pumps the water or the blood in this case off to the lungs. The lungs are the furnace. That's where your water in your central heating system gets heated. Or the blood gets oxygenated, and then it comes back, in the case of the body, it comes back to the pump to be pumped everywhere. Those organs, they're your radiators, that's where the heat's given off. In the central heating system, in this case, it's where the oxygen's used up and the carbon dioxide is replaced, and then of course it comes back to the heart for the system to repeat, as the central heating system does. It's a closed circuit. The water that heats the radiator comes back to the boiler, it gets passed over the furnace again, and then it gets recirculated to the radiators. We don't use a constant stream of kind of mains water, as we don't in the body. We don't have a constant supply of blood. We have around 70 mil per kilo, 75 mil per kilo. So most of us are in that kind of 6 litre-ish. So we don't have limitless supplies. We can cope without some of it, but ultimately we'll start to show signs of shock, clinical shock, where we start to lose too much. And again, we'll talk about some of that in the pathophysiology session that's coming up. This is a bit of an overview. Obviously, every part of the body has a blood supply. Every part of the body uses oxygen and gives off carbon dioxide. So fabulous. So let's look at this. So this is the kind of upper, the upper area of the cardiovascular system, if you like. So here we have the heart in the middle. The heart pumps blood. So the right side of the heart deals with deoxygenated blood, and that pumps blood to the lungs and back. The left side of the heart deals with oxygenated blood and pumps blood to all of the organs. So the blood going to the lungs and back is known as the pulmonary circulation, and the blood going to the body and back is known as the systemic circulation. You'll notice that on this diagram, the blue vessels are those carrying deoxygenated blood, the red vessels are those carrying oxygenated blood. There's always an element of confusion in the pulmonary circuit because don't forget, the blood leaving the heart going to the lungs is deoxygenated and the blood coming back is oxygenated. There's a rule that you need to be aware of, and that's any blood, and if the vessel is leaving the heart, i.e. the blood is being pumped away from the heart, it is doing so in an artery. So regardless of whether it's oxygenated or deoxygenated, if blood is leaving the heart, it's doing so in an artery. As you can see, the blue one leaving the heart there, going to the lungs at the top, is the pulmonary artery. And any blood coming back to the heart, obviously it's not being pumped back to the heart, it's just kind of naturally returning, then that is doing so in a vein. So arteries always leave the heart, veins always return to the heart. In the pulmonary circulation that you can see in the center here, the oxygenation and deoxygenation is reversed because obviously there would be no point pumping oxygenated blood to the lungs. That's what they're there for. But if you want to sell ice to Eskimos, then carry on. So the anatomy of the heart, then let's have a little look. So let's focus on blood flow through the heart and this diagram here on the left. So we've said that the right side deals with the deoxygenated blood. So the right side of the heart is less muscular than the left. The left side is much more powerful. That is just that makes sense if you think about it. The left side of the heart is pumping blood to the top of the head and to the bottom of the feet. The right side of the heart is only pumping blood to the lungs and back, so it doesn't need to be as strong. That being said, the volume being pumped is the same, it's just the pressures are different. Obviously, if the volumes were different, you would have a bit of a mismatch somewhere, and actually that's what happens in heart failure, which we will talk about in our pathophysiology session. I tend to start, when I talk about blood flow through the heart, I tend to start with the right atrium. Blood naturally kind of pulls back at the top of the heart. So the heart, for the real basics, is split into 4 chambers. You have two atria, a right and a left atrium, the atria being the entrance halls, as it would be an atrium in a building. That's where the blood kind of pools and waits for the ventricles to be ready. Don't forget that the atria contract, as do the ventricles, but the atria contract first. They do that to pre-fill the ventricles so that the ventricles are as full as they possibly can be. So when they contract, the amount of blood ejected is as high as possible, therefore making the heart as effective as possible. If you're pumping out lots of blood with each beat, you don't need to beat as often or as hard. Okay, so blood naturally kind of returns under some residual pressure, returns through the vena cava. So superior and inferior parts of the vena cava meet here in the right atrium. Blood is pooling there constantly. And then when the time is right, the atria contract, they push that blood through this tricuspid valve into the right ventricle. When the right ventricle is pre-filled, and we'll look at the electrical system very briefly in a second, just to show you how that kind of works. Once the ventricle is pre-filled, that tricuspid valve shuts, the ventricle contracts, and that pushes blood out through the pulmonary valve into the pulmonary artery. From the pulmonary artery, it goes to either lung, it's oxygenated, and it comes back under residual pressure into the left atrium. In the same way that the vena cava just naturally fills the right atrium, the pulmonary veins naturally fill the left atrium. Exactly the same process. When the left atrium is ready to, or when the left ventricle is ready, the left atrium will contract. That will pump any blood that's in there through this mitral valve. The mitral valve then it pumps through into the left ventricle. When the left ventricle is ready to contract, the mitral valve will close. The left ventricle contracts, pushes blood out through the aortic valve into the aorta and around the body. From the aorta, blood goes everywhere. This is the highest pressure that the blood is under anywhere in the body, and quite understandably so. That's where it's going to be distributed everywhere. And then the whole cycle repeats when it returns through the vena cava to the right atrium. So you're never going to learn that first time round. So if that's the first time of hearing that, that might seem very complicated, but by all means, go back and watch this over. And just have a little think. But right side of the heart deals with deoxygenated blood. The left side of the heart deals with the oxygenated blood. So right atrium through the tricuspid valve into the right ventricle, from the right ventricle through the pulmonary valve into the pulmonary artery, to the lungs and back, into the left atrium. Left atrium goes through the mitral valve into the left ventricle through the aortic valve into the aorta, to the rest of the body, comes back to the right atrium, the cycle repeats. Brilliant. Hopefully everyone's still with us there. Just thinking about the anatomy of the heart a little bit more detail. So there's 3 layers of heart muscle. So we have the outer pericardium, which is the fibrous kind of protective layer. We have the middle myocardium. That's the bulk of the heart wall. The heart is a muscular organ. The myocardium are the cardiac myocytes. They are muscle cells. You'll hear the term myocardial infarction, which is death of muscle tissue. So when somebody is having a heart attack or an MI, myocardial infarction, it is this part of the heart that is dying. And if this part dies, the heart doesn't contract properly. You get some element of heart failure. We'll talk about that in a couple of weeks' time in pathophysiology. And then you have the thin endocardium. That's the inner layer. Think of that as your Teflon layer on your frying pan. That's to stop anything sticking. You don't want any clots forming within the heart. We'll talk about atrial fibrillation at some point during this series and explain why clots sometimes do form in the heart, but they shouldn't do. And this Teflon endocardium is designed to kind of stop that. So pericardium on the outside, that's a fibrous protective layer. You've got the myocardium in the middle, which is the muscular layer. That's the predominant area of the heart. And obviously that's thicker on the left ventricle because that's the harder working ventricle. And then you have that Teflon inner endocardium. You may notice that there is a pericardial cavity. There's 2 layers of pericardium. There's a parietal and visceral pericardium. In between the 2, there's a small layer of pericardial fluid, and that just allows relative movement between the muscle and the outer layers and the outer structures of the heart. If you've heard the term cardiac tamponade is blood within that pericardial cavity. So if someone suffered a traumatic chest injury, sometimes you can get cardiac tamponade, which is blood forming there. If blood forms within that pericardial cavity, it can sometimes make it very difficult for the heart to beat, and that patient can go into cardiac arrest. It's one of the reversible causes that we'll talk about in immediate life support, but for now, just bear in mind that's what's going on there. So, coronary circulation, just very briefly. So we've got, broadly speaking, 2 coronary arteries. They come, they're the first branches off the aorta as it arches out of the top of the heart. They're protected from the massively high blood pressures in that area because the aortic valve, the cusp of the aortic valve, open onto the left and right coronary arteries. So effectively, they're filled with back pressure as opposed to the direct pressure of the left ventricle beating, if that makes sense. You wouldn't want to put these huge kind of systolic pressures through these tiny little arteries directly. So it's a good little design feature there, whoever made the heart. So the left one, we generally just consider splits into 2, otherwise it gets a little bit too complicated. So the left coronary artery splits into the circumflex. The circumflex winds its way around the side. We have the left anterior descending, which, as the name suggests, predominantly feeds the front wall of the heart and heading down towards the inferior, the bottom of the heart. And then we have the right coronary artery, which supplies the rest of the bottom of the heart, and it also loops its way around the back and supplies a lot of the posterior wall. So we have the 4 kind of sides of the heart, if you like, are kind of covered by these 2 vessels. The left coronary artery obviously supplies a lot more of the heart, and it is a lot more critical if it becomes blocked. But when we talk in pathophysiology a bit later about heart attacks and angina, that is narrowing or blockage of these coronary arteries. And of course, you can see already, I should imagine, that it depends where you block those coronary arteries as to how much damage and what type of damage is being done, which part of the heart is affected. And we've just shown you in that last diagram the myocardium. It's the myocardium that does the work in the heart. If you kill that myocardium, as in the case of a heart attack, an MI, you will, of course, affect the heart's ability to beat. And if you do that too much, ultimately, the heart won't beat anymore. So that's why these heart attacks sometimes can be very, very much immediately life-threatening. So, but that's just to give you an idea of the blood supply to the heart. We will talk about pathophysiology with these vessels a little bit later. So say in a couple of sessions' time, we'll do a pathophysiology. Very briefly, because we are going to talk about ECGs on another date, but this is just to give you an idea of how the heart sorts itself out. There's an electrical conduction system which oversits the muscle, if you like. So the muscle responds to electrical signals. and it will beat when it's told to by these electrical signals. You have the natural pacemaker of the heart, the SA, sinoatrial node up here at the top of the right atrium. That sends signals across the atria. So you have Bachmann's bundle, which goes over to the left atrium. So that sends electrical signals across both atria, both tops of the heart, and that causes them to contract. Now, what happens then is the electrical signal travels down through these internodal pathways and Bachmann's bundle, and it all arrives here at the atrioventricular node, the AV node. It's held on to at the AV node for a little while. So that electrical signal doesn't just hit the AV node and then trigger the ventricles. And that's because what we were talking about a little bit earlier, if blood is sitting in both of these atria, ready to fill the ventricles, there's no point squeezing that into the ventricle and then immediately squeezing it back out of the ventricle again. That wouldn't make sense. So what we do is we squeeze blood in there, we allow it time to fill, and then when the system is ready, then the ventricles contract. So what we have is electrical signal leaving the SA node, traveling through these internodal pathways to the AV node. In doing so, it causes the atria to contract. The electrical signal is held onto at the AV node for about 120 to 200 milliseconds to be precise, but we'll talk about that in more detail. And then when the ventricles are ready, it's released. It travels down through the bundle of His into the left and right bundle branches. Okay, the left bundle branch, in very much the same way as the blood supply does, this splits into two. So you have the anterior division and the posterior division, but we don't need to go into those in any detail at the moment. It's just worth noting that as these bundles travel down, they split and split and split in very much like the way that the bronchioles did in the lungs. And you have these Purkinje fibers, which are basically like the terminal ends, these little fibers that spread out across all of the myocardium, the heart muscle. And in doing so, when they send electrical signals into that myocardium, it causes the heart to contract. It does so in a coordinated manner. When this system works, it works really, really well. Again, we will talk in pathophysiology a little bit about what's going on when the systems aren't right. We won't do too much ECG on this session because ultimately for FREC 4, you don't need to know a huge amount about ECGs. And I don't want to confuse any of you that are studying for that at the moment. But there will be more ECG sessions coming off the back of this. So if that's something that interests you, then stick with it. But that's the electrical system in a nutshell. There will be a very basic ECG session coming in this series for those of you that are interested in that. So blood vessels, there's 3 layers of blood vessels in much the same way there's 3 layers of the heart. They're called different things, of course they are, because nothing's simple in medicine. Tunica adventitia is the outer layer, that's the tough fibrous layer. Then you have the tunica media, which particularly in arteries is quite muscular. We can contract our arteries to control our blood pressure. And then you have the tunica intima, which is the Teflon layer. Again, you don't want blood forming in the arteries. The blood should only clot on the outside. We don't want any blood clots on the inside, realistically. So we have Teflon layers within there. So rather than the pericardium, myocardium, and endocardium, we now have the tunica adventitia, tunica media, and tunica intima. And as I say, the arteries are a little bit more muscular, so that tunica media is a little bit thicker in these arteries because we like to be able to contract our arteries when we need to bring our blood pressure up, and likewise relax them, dilate them when we want to reduce our blood pressure. So well done for sticking with us. This is just to show you that blood goes all over the place. The aorta, as you can see, the aortic arch coming out of the heart, and then the descending abdominal aorta, descending thoracic and abdominal aortas. And then it splits into the femoral arteries, which go down each leg. Off the aorta, you've got the subclavians, and they then become the brachial and radial and ulnar arteries. And then, of course, they go up into the carotids and into the circle of Willis in the brain, and then supply the brain. So the network is really quite simple but complex at the same time, if that's not an oxymoron. It's a fascinating system, but lots to know if you want to learn it in any real detail. There is a venous system as well. For every artery, there's a vein. Ultimately, the blood has to come back. We don't just send blood on a one-way ticket. So the venous system brings that blood back to the heart. It's not an active system. Ultimately, blood is returning through residual pressure. As your blood goes out to the peripheries, your blood pressure drops slowly but surely until you get to the capillary beds, and then obviously that residual pressure just carries it back up through the venous system. Within the legs, we have the muscles within the legs, and also some valves just to help get that blood, because we spend a lot of time standing up as humans, so we need a bit of help just to overcome gravity to get that blood back up from the legs. and hence why legs are often the first places to swell with edema when people get heart failure. Blood flow to the mediastinum. The mediastinum is just the cavity that the heart lives in. It's the heart and a couple of endocrine producing organs that live within the mediastinum, but it is just a cavity. So there's no kind of difference to the blood supply in there, if that makes sense. So it's just the kind of in capsule that the heart lives in. Fab. So cardiac cycle, just to get some terms in there. I appreciate this session is going to run over a little bit, so I do apologise. Hopefully you're finding it useful. The heart actually for most of the time isn't doing a whole lot. It's actually in diastole, so diastolic most of the time. Diastole just means there is no heart activity. Okay. Then we have atrial systole. Atrial systole is when the atria are contracting and pushing blood down into the ventricles. And then we have ventricular systole. That is when the ventricles are contracting and pushing blood out through the pulmonary artery and the aorta. So you may hear the term, and certainly will if you're learning to take blood pressures for the first time, you'll hear the terms systolic and diastolic. The blood pressure that we're measuring at systolic is the maximum pressure in the artery we're measuring, of course. Most of the time we do blood pressure on the upper arms, so we're measuring the brachial artery pressures. We're measuring the highest pressure during ventricular systole, and then we're comparing that to the average pressure at diastole, so when the heart is relaxing. Now, there will always be, as I've said, there will always be some residual pressure, otherwise the blood would never come back to the heart. So the diastole is, or diastolic is never zero. It's actually normally kind of in the region of 60 to 90, isn't it, typically? Anything much lower than that, you find the heart doesn't pre-fill enough. But diastole is just the heart at relaxation. It's the pressure within the artery when the heart isn't pumping, and there should always be a good residual pressure, but we don't want it too high. Too high suggests that there's build-up of lipids and cholesterol and things like that within the arteries. But as you can see from this diagram, this is actually the heart predominantly is in diastole. It's only in systolic. That second that you feel your heartbeats, that is ventricular systole. So you all feel your radial pulses. Now that beat you can feel is ventricular systole. When we're listening to blood pressures for the first time, that's the beat we're hearing. And that's how we know what our systolic blood pressure is. The diastole you can't hear. It's just a case of learning how to do manual blood pressures. Good. We're at the end of cardiovascular. I'm sorry, I know it's pretty heavy, isn't it? The big three, and we've still got nervous to go, although the nervous system, there's not a huge amount to know. So let's go back to Mentimeter. So menti.com. Let me just make sure results are hidden so we don't ruin it for everyone. So we're going to talk about the respiratory system now then, aren't we? So which of the following is true about the pulmonary circulation? So menti.com 35194182 and A, B, C or D. So oxygen levels in the pulmonary vein are high, oxygen levels in the pulmonary artery are high, carbon dioxide levels in the pulmonary vein are high, carbon dioxide in the pulmonary artery are low. Which one do you think? How much of that has made sense? So oxygen levels in the pulmonary vein are high, oxygen levels in the pulmonary artery are high, carbon dioxide levels in the pulmonary vein are high, carbon dioxide in the pulmonary artery are low. Go on, which organ does not have a blood supply? Oh yes, that's true. Very good. Good, so some of you voting, I'll give it a little bit more time before I show you where you're going. So are oxygen levels in the pulmonary vein high, or oxygen levels in the pulmonary artery high, carbon dioxide in the pulmonary vein high, or carbon dioxide in the pulmonary artery low? One of those is true. Here we go, half of you voted. Good. Perfect. Well done. You are, of course, right, 55% of you. So oxygen levels in the pulmonary vein are high. So a vein is coming back to the heart. So the pulmonary vein is going from the lung to the heart then by definition. Oxygen levels should be high. The pulmonary artery is going from the heart to the lungs. So oxygen levels are going to be comparatively low in that. Carbon dioxide levels in the pulmonary vein are actually low, aren't they? And carbon dioxide levels in the pulmonary artery are high generally. So A is correct. Well done to 57% of you. That's got that. So we're going on to the nervous system now then. So give me some ideas. What's the function of the nervous system? Thanks, Joel. Take care. Sorry, it's gone on a bit. So pop your answers up. What are the functions of the nervous system? Homeostasis, I like it. Respond to stimuli, good. Transmit signals, absolutely. Send commands, homeostasis, popular word, good. Communicate to muscles, conduction of impulses, I like it. Functional control, protection, movement, sensation, wow, good stuff. I like it. Lots of answers coming in. Perfect. So lots of people going, yeah, absolutely. So lots of communication, lots of transmission, lots of sensory information, responding to stimuli, innovation, absolutely. Good functional control. Don't forget your kind of thought processes and things like that. Absolutely, well done. So let's get back to our slideshow then. So nervous system functions, actually very basic levels. It's sensory function. So it's sensing things, ultimately pain or kind of whether or not our body is at the level it wants to be, whether we're homeostatic or not. Information processing, so basically signals are received, they're transmitted to the brain for information processing. That's where our thought processes take place, whether or not they are conscious or otherwise, we'll talk about in a minute. And then motor functions, so we have to sense something, we have to think about it, and then we have to do something, generally speaking. Okay, now these are going on in every kind of area that you can possibly think of. So not so much just, you know, ultimately if I touch something and think actually that doesn't feel very nice, then of course that has been a fairly conscious thought of actually, and you've processed that and thought that was a little bit uncomfortable, I don't want that, and you take your hand away, for example. Now it's a little bit different from reflexes. Reflexes are that, but in a very quick kind of unconscious way. So reflexes are actually dealt with in the spinal cord itself. It doesn't actually transmit all the way up to the brain. So what we have there is sensing pain or sensing heat or electric shock or something like that. We have a very split-second decision to remove our hand from that, and that motor function happens without us being aware of it. That signal then travels up to the brain to tell the you know, our conscious thought, actually that's what's happened, and we do it without thinking about it, don't we? So that's going on all over. So predominantly the nervous system is the brain, and spinal cord, the central nervous system, and the peripheral nervous system is anything that spreads off that. Now, broadly speaking, we split that into the cranial nerves and the spinal nerves. The cranial nerves, generally, apart from one, deal with everything kind of around the head and neck, and then the spinal nerves deal with everything lower down in the body. So, and there's a complicated picture coming up which can show you just how much that is. So we've got some divisions, central nervous system being the brain and spinal cord, the peripheral nervous system literally being everything else, broadly cranial and spinal nerves. The somatic nervous system and the autonomic nervous system are the two terms I'm going to throw in there. Somatic means conscious thought, and the autonomic nervous system is unconscious thought. Autonomic being close to automatic is the way I learned it back in the day. Somatic being kind of skin and things like that, isn't it? And skin and skeletal muscle is things that you're generally aware of. So somatic nervous system deals with the voluntary actions, but also reflexes. Reflexes are controlled by the somatic nervous system because we are aware of them once we've done our reflexes. That makes sense. When you jump, you're always aware that you jumped, or when you touch something and pull your hand away because it's hot, that's you're always aware of that. The autonomic nervous system, we're going to split into two main areas, and that's the sympathetic division and the parasympathetic division. We don't need to go into huge amounts of detail at this level. By all means, there are loads and loads of resources out there for the nervous system if you're interested. But broadly speaking, it's an electrical wiring system that allows very, very rapid transmission of messages. The brain and spinal cord is where things are thought of, or where the information processing happens. Obviously, mostly in the brain. The spinal cord is a very quick nerve transmission pathway, but of course, some of the reflexes are dealt with in the spinal cord as well. The peripheral nervous system is literally just the wiring system that connects that to every other system that needs to have an innovation, as in control of the nervous system. The somatic one being the ones that we think about, and the autonomic one being the ones that we don't think about. The sympathetic and parasympathetic division are really important to have a basic understanding of. The sympathetic division is often called your fight or flight, and that's going to do everything in the body it can to ready you for running away from danger ultimately, or fighting danger. The parasympathetic division is your rest and digest, it's often referred to, and that is once you're calm and peaceful, and it tends to slow everything down in the body, divert more time to things like gastric motility, so allowing breakdown of food and so on and so forth, as opposed to working up adrenaline and all these other bits and pieces. So we're going to have a look at the brain in a little bit. So these are the parts of the brain. The cerebrum is the main part. The outer layer is known as the cortex, the cerebral cortex, and that is the part that's associated with conscious thoughts. Everything else is unconscious thought, which just shows you how much is going on unknowingly. It's only a very thin outer layer of the cerebrum, the cerebral cortex, that's actually associated with stuff that we're conscious of. The diencephalon is the kind of the middle of the brain, if you like. So that's the hypothalamus, thalamus, and the pineal glands, or epithalamus. The pituitary gland is very important in hormone control. So this is where the nervous system and the endocrine system often overlaps, like the endocrine being the hormone system. And then we talked about the brain stem, didn't we, a little bit earlier? So you have the midbrain, the pons viruli, and the medulla oblongata making up the brain stem. And we talked about respiratory centers being within the pons and medulla, as are a lot of the cardiovascular system. So a lot of the staying alive kind of control of the body is dealt with in the brain stem. It's the most kind of central and protected area of the brain. And then of course that disappears down as the spinal cord into the cervical neck and down into the thoracic and lumbar vertebrae. Good. Calcification of the brain related to dementia, absolutely. So yes, Casey. So that's build up of calcium within the brain, or calcification within the brain, is things like Lewy body dementia, and it's an aging process, and yes, will ultimately result in loss of cognitive function, so brain function. But yes, absolutely right. Good. So we've got some protective layers around the brain. Don't need to get too in depth with these names. So underneath the bone of the skull, we've got three protective layers between that and the brain itself. They are known as the meninges. We have the dura mater, the arachnoid mater, and the pia mater, in that order from outside to inside, and they all provide an element of protection of the brain tissue. The arachnoid mater in particular allows a bit of a cushioning mechanism to happen, in that that is where the cerebrospinal fluid kind of circulates in that subarachnoid space underneath the arachnoid mater. And that allows the brain to move relative to the skull with some cushioning, so that when we bang our head, we don't automatically get a bleed and die. We need some area of protection from that. Now you'll see that within that subarachnoid space underneath the arachnoid mater, you can see there are some blood vessels. Subarachnoid hemorrhage is therefore one of the more common brain bleeds, and a hemorrhagic stroke is just that, a subarachnoid hemorrhage. When we talk about pathology of the brain, which we will talk about in a future session, we describe it in relation to these meninges. So subarachnoid means underneath the arachnoid, subdural or extradural being outside the dura mater. Hopefully that helps just explain that term. So that's there. We will talk about meningitis. We will talk about intracranial hemorrhage and strokes and things like that in a later session. So, cranial nerves, I've put them on there just in case anyone's interested. You certainly don't need to learn these for the FREC 4 syllabus, but they are there for you. They spread off. This is looking up at the brain from underneath, if you like. So, and they are numbered using Roman numerals traditionally. So we have the olfactory, which is for smell, sense of smell. Then we have optic, which is obviously visual, oculomotor, which deals with some eye movement, as does trochlear, abducens. Vestibulocochlear looks at balance and hearing. Where are we? Gone out of numerical order. So trigeminal looks at your face, as does the facial nerve. Glossopharyngeal is the tongue and back of the throat. The hypoglossal and an accessory again deal with mouth and neck and shoulders. The vagus nerve is often known as the vagrant vagus, because it wanders all over the place. So the vagus nerve is the only pair of nerves that go outside of the cranium, if you like. So we've talked about head and neck being the cranial nerves. The vagus is the pair of nerves that is the odd one out there. There's plenty of reading around cranial nerves if that's something that interests you, but certainly it's just to be aware of at this stage. So a neuron, then, this is the functional part of the nervous system, which everyone tends to get a little bit stuck with at times. We are nearly there, guys. I know it's gone over a little bit, but it's inevitable with such a big subject. So neurons, I think the interesting thing, and when I learned about this for the first time, I found quite interesting, was actually neurons are quite big cells, well, really big cells in some cases. So this part of the cell here, the cell body, may well be, you know, up in the top part of the spinal cord or up in the brain itself. And this synapse down at the axon terminal here, at the very far end, may well be down in your foot. So actually, these nerves can be huge. So that was, I thought, quite interesting. I was just kind of I read textbooks in the beginning, I just assumed one was connected to the other, but actually these may well be really, really long, really long nerves themselves. So in some cases they do connect one to the other, but often they are very, very long. So the cell body is where signals come in. This is a one-way electrical circuit. Think of it as wiring in your house. So the electricity only just goes in one direction, though, within the body. So electricity comes in through through the cell body, through the dendrites, they're called. They're the functional parts. They're the receiving parts, and then that allows the cell to process an electrical signal down its axon. Its axon is its long, sticky, outy bit, to the axon terminal and the synapse. The synapse is where this cell then communicates with another cell, whether that be another neuron or whether that be its target organ. So, you know, this might be the part of the brain up here that thinks about kidney function, and actually the synapse here is directly attached to the kidney. I mean, it's not in real life, but that's just an example. So that's that. Now, there's a couple of terms along here. The axon terminal needs to be insulated, otherwise it's just going to short circuit with other neurons around it. So you have the Schwann cells. Schwann cells grow where am I at? So the Schwann cells grow these myelin sheaths. So this sheath that's around, funny enough, it's not labelled for some reason. So these Schwann cells, they grow myelin sheath. Myelin sheath is insulation for the axon, and in between these myelin sheaths are the nodes of Ranvier. Nobody really understands why they're there, but it looks as though having these gaps in the myelin sheath actually allows the signal to be transmitted faster without any kind of cross-contamination with other nerves. So it's pretty clever stuff. When the myelin sheath breaks down, that's known as multiple sclerosis. That was obviously going to cause short-circuiting of electrical signals from one nerve to another in a whistle-stop tour. So the axon is the long, stretchy bit. The axon terminal and the synapse is where the signal is deposited to the next cell. You have the Schwann cells, which grow myelin sheath. Myelin sheath is the protective insulating layer of the axon, and the dendrite and the cell body is where the signal comes in. This was this complicated diagram I told you about, so I find this quite useful if you're doing anything in any more detail. It's just knowing where the nerves come off the body. You don't by any means need to know this in any detail, but it's nice to know, for example, that the nerves that supply the skin and area of muscle around the back of the leg, for example, comes off at S2, so that's right down at the low level of the spine. But I'll leave that on there. That's on the the slides that you can download tomorrow. So that's the end of the theory, guys. Well done for sticking with it. Let me just go back to this, and we've got one more quiz question just to end this evening. So it's back on to menti.com 35194182. There's the number in the chat. Thanks, Charlotte. Which of the following would be a function of the sympathetic division? So the sympathetic division: a reduction in breathing rate, a reduction in heart rate, an increase in gastrointestinal activity, or adrenaline release. Which of the following would be a function of the sympathetic division? Reducing breathing, reducing heart rate, increasing gastro activity, or releasing adrenaline. I'll let kind of half of you get a chance at voting, and then we'll wrap up. Still a few more coming in. Good. Okay, so reduction in breathing rates, reduction in heart rate, increase in gastrointestinal activity, or adrenaline release. It was, of course, adrenaline release. The sympathetic nervous system is your fight or flight. When you're fighting or flighting, you want to increase your breathing rate, you want to increase your heart rate. You don't want the stomach using up all your precious blood supply, so you tend to slow down your gastrointestinal activity, and you release adrenaline. Adrenaline release is associated with the sympathetic nervous system. The way I remember that, the sympathetic nervous system and the parasympathetic nervous system, paramedics are there to calm people down. The parasympathetic nervous system does just that. It calms you down. The sympathetic nervous system riles you up and puts you on edge. I think I can't remember the lecturer that told me that, but it stuck with me. So paramedics calm you down. Not always, but there we go. Right. Back to the end. There we go. Thank you very much, guys, for bearing with us. Obviously, we're a little 15 minutes late, but I think that's pretty good going considering how much subject material we've covered. If anything didn't make sense, please do feel free to drop us an email or anything like that. Or these videos will be uploaded to YouTube tomorrow, so you can have a watch of those again if anything didn't make sense, and do get in touch. You're more than welcome, guys. If you've enjoyed tonight, we do ask that you leave us a review. Charlotte's just put the review links up there. It really does help us. Obviously, we want these webinars to be free, but in return, if we can attract some new customers to us, that's always useful. If you'd like a certificate, Charlotte's just going to put a link into the chat. There are CPD certificates. You'll be able to get the link on our website tomorrow and on Facebook as well. Links to the reviews and to the oops, what's gone on there? Goodness me. And to the CPD are there. Brilliant. Well done, everyone. Thanks for bearing with. There's been no questions I've seen in the chat so far. You're welcome. Everyone that's leaving, have a good evening. We'll be back next Wednesday, the 28th of April at 7 o'clock. And then, as I say, the week after, we'll go back to Monday. So next Wednesday at 7 o'clock. For the rest of anatomy and physiology, it will be a shorter session. We hope to see you then. And I'll take questions now if there is anyone that has one. So links in the chat to get your certificates and to leave us a review if you so wish. Otherwise, everything will be on our website and Facebook tomorrow at some point. And hopefully that's been useful to everyone. You're welcome, everyone that's leaving. I'm glad it's been useful. We hope to see you next week. If there's no questions, I'll